So next, we move ahead to one of the videos from our exhibitors panel. So let's watch it.
Yeah, I just want to thank our panel again. Can we please have a round of applause? Really appreciate everyone making time for coming here. Thank you all.
So now we have Care Experts video being played.
Hi, this is Anuj Jain, Managing Director for Care Expert. I would like to first thank NASCOM and all the delegates who made this event happen. In India, next 10 years is one of the biggest digital revolution in the field of healthcare because we don't have the hospitals fully digitized or they are today minimally digitized. We have seen the success of UPI because there was a banking system existing for last 20-25 years which was fully digital. Same is needed in here. Today when we visited in last 18 months we have lit 200 plus hospitals on our health cloud. Even the best hospital IT systems we find disjointed products, monolithic architecture, they are too costly. They are to be integrated and then finally they result into broken patient journeys, poor patient experience, care professionals are dissatisfied, and in order for us to enable the disruptive solution, we need the AI readiness, mobile readiness, cloud readiness for these solutions. There is a need of platform-based solution rather than product and integrated solution where things comes integrated. It's a full stack solution from Care Expert where we'll digitize the hospital end to end and make them paperless, make them fully digital, enable better financial efficiencies, better operational efficiencies. The integrated data lake is a addition on top of the basic platform of HIMS, EMR, EHR, which enables a online transaction data and the migrated data to come into a single data lake so that all the data and all the care professionals they can work on a holistic environment, building a complete clinical records of the patient across different episodes so that there is a single EMR view, all the patient records in terms of OPD, IPD, they are part of the clinical data lake. All their MRD data can be fully digitized and put under the same EMR view. Complete PACS data and its view under the EMR view is available to the radiologist. Then the CXOs of the hospital can work on the financial data part of it, and we have taken this thing for the next level where the hospital chains can be fully digitized when they have multiple facilities of the hospital, which enables even better quality of care for the patients. This is what we do, and there are several applications on top of the data lake which we customize for the customers. And I would like to just say that this is the beginning of the AI powered hospitals, because once you have the data, the generative AI, the operational AI, the clinical AI, they all become possible. So this is our first milestone. Thank you so much.
So now, ladies and gentlemen, glue yourselves to the tables for a few more minutes as we are coming to our last session for the day. Let us welcome the next session, Digital Impact in the Primary Healthcare. Now let's welcome our panelists, Mr. Neeraj Jain, Country Director, India and Director, South Asia at PATH, who is the moderator for this session. Mr. Neeraj.
The hall needs to be full. What can we do for that? And the startups have been complaining that there's no gift for them. So let me produce something for them. And it's open to anybody who can do that. Can you hold this for me? So there is a very small exercise. I am not sure whether you can do it, but I have learned the art of doing it. do this. Rotate in different directions, which means that, and look carefully, because this is a human tendency that it goes into the same direction. Look at what I am doing. These are two different directions. Wrong, wrong, wrong. So do it very slowly. Concentrate. Let them go into different directions. Very slowly. No, everybody is doing wrong. So I know it's a little tough, but try to do this. Whoever can do this like this, and you can do like this, okay? We have some gifts. No, so I'm giving you 3 minutes for the next panel to exercise and practice it, but your ears should be attentive to them. All right? So I have gifts for people who can do the fastest bi-directional movement of hands. All right.
I'm going to practice. I think we should forget about the panel. I think I want the gift. So
let's welcome Mr. Neeraj Jain. Mr. Neeraj Jain, a physician with 3 decades of public health experience in primary healthcare, managing infectious diseases and delivering vaccines. So the next one in the panel, we have Dr. Shubhankar Bhasak, India Health Innovation Hub Leader at AstraZeneca. Dr. Shubhankar, accomplished business professional with 15 years of diverse experience in cross-functional areas with exposure of working in multicultural environment and in multi-sector business segments. So the next one in the panel, we have Mr. Ashutosh, who is the head of digital business, Care Health Insurance. Please join your hands together for Mr. Ashutosh. He has over 15 years of experience across health, general and life insurance, including as founding member of Religare Health Insurance, wherein he anchored the retail business strategies across the agency and much more diversifications. Last but not the least, we have Mr. Girish Krishnamurthy on the stage, joining us for the panel. Please give him a big round of applause. Mr. Girish Krishnamurthy is the Managing Director and CEO at Tata Medical and Diagnostics Limited, a high-growth CEO who is in addition steered several companies as a board of director, advisor and mentor with over 3 decades of his rich multi-domain and entrepreneurial experience across key sectors like healthcare, software products, IT services, skill development, education, manufacturing, retail, and airlines. Girish has successfully led multiple transformational initiatives globally. So now I would ask the moderator to take up on this session. Give them a big round of applause, everybody.
thank you. Thanks a lot. Is the mic working? Yeah? A very good afternoon to you. I don't see you practicing. Come on, you need to keep practicing if you want that gift. So I can see the clock hasn't started yet, but that last sound is quite scary. So what we'll do is we'll go a little bit rapid fire, if that's okay with my co-panelists. And so let's start with a quick round of introductions. So do you want to go first, Shubhankar?
Sure.
Just like a rapid response.
Absolutely.
Go for it.
Good afternoon, everyone, and thanks to NASSCOM for this opportunity. So I'm Shubhankar, leading innovation in AstraZeneca. I'm sure you all know about AstraZeneca now after the COVID vaccine that we have produced. Nice to be here. Thanks.
Thank you. Girish.
It's time to believe that healthcare can be transformed.
Fantastic. Ashutosh.
So, hello everyone. I am with Care Health Insurance. I head their digital business as of now, but I've been with them since 13 years. And across various roles, I've handled products, underwriting, and technology interfaces for them as well. So, very happy to be a part of this panel.
Thank you. And I'm Neeraj Jain. I'm the Director South Asia for PATH. PATH is a not-for-profit working in the health sector. And unfortunately, Pooja couldn't be with us. And I must quickly tell you that I have actually pledged not to be on a panel. But unfortunately, Pooja dropped off. And I almost didn't come on this panel, but the organizers requested that I should continue. So this is just for the record. Let's start straight away into our conversation. It's an important one because we are talking about technology and primary healthcare. As we all know that our primary healthcare system, because of the size of the country, because of the geographical spread, we just don't have enough people or enough manpower or enough women power to actually run our primary health centers to the best. Technology is probably one of the ways that we can actually reach population levels when we want to try and make health impact across the country, especially for those who really need support and can't afford. I'll come straight to Shubhankar. Shubhankar, what I found intriguing was when you introduce AstraZeneca, you talk about the vaccines. But I know you have nothing to do with the vaccines.
Yeah.
So that's brilliant. So let me come to you and say, okay, if you were to think about primary healthcare and digital technologies, what are some great ideas, things that you've seen or you've been a part of that have really, you've felt that this is going to really have an impact in primary care? Go for it.
Great question. I'll give you a couple of examples. Before that, see, India is going through a couple of transformation. Economic transformation. We are, our ambition is to reach to 5 trillion economy, right? Then, there is demographic transition. 60% of our population is in the working class. We need to take that dividend out of that. However, if you look into the epidemiology transformation, we have seen today morning in the keynote speaker, it's changing from communicable disease to non-communicable disease. And if you look into the data, maybe he also showed, how the death rate has increased in NCDs. So it's very, very important we should focus on our primary health so that we can take that demographic dividend and achieve what is the country want to achieve in next 5-10 years time. So in AstraZeneca, we not only produce world-class medicine, we also try to provide beyond the pill solution to our customer to provide them the better experience and outcome. So I'll give you a couple of examples. In the lung space, lung cancer is a very challenging healthcare problem because there is huge mortality rate. The number of patients detected every year, almost the same number of patients die because of lung cancer. There is no screening tool for lung cancer, which is nationally available. And there is 20% of the cases also misdiagnosed as tuberculosis. And that paper came from Mr. Randeep Guleria's lab in AIIMS. So we thought of how we can solve this problem. Because there is no biomarker available, and then we found out a startup solution called Cure AI, and we are working with Cure AI not only here in India, in almost 20-30 different countries across the world. So what it does, it actually analyzes the chest X-ray and then try to interpret what are the different lung elements that can able to detect. And they can detect about 29 different lung diseases, including TB and lung nodule. And believe me, lung nodule are the precursors of lung cancer in almost 60% of cases. So this is affordable solution, accessible solution. So we are working with Cure AI in different state governments, Jammu Kashmir, Assam, Kerala, and we have done pilots in these states very successfully. Now we are trying to commercialize this solution into different states. So this is one example of digital technology, AI-based technology, how this can transforming the lung cancer space. And another solution which actually came out from the NASCOM and BIRAC Jan Care Challenge called LHIF-11. That is also in the lung space. If you look into the pulmonary obstructive disease, the first line of diagnosis is spirometry. Now, spirometry in a conventional way, it's costly, not accessible. There are published data which shows in the GP and CP level, the penetration is very low. So we thought of how we can solve this problem, and we found out LHIF-11 through our innovation challenge, and we are working with them They have a small digital handheld spirometer, which is IoT-based spirometer, and it can connect it. So patients can come do the spirometry test. Doctor can sit, miles away and identify what are the challenges. So these are the two solutions we are working out of many others and try to provide a better experience and outcome to our patients.
So fantastic. I don't know if some of you were there in the morning when Girish talked about AIMS, 10,000 people landing up there every day. Yeah. If we strengthen our primary healthcare facilities, Girish, how many of those would not be there? Tell me.
Okay. So I think most of that need not be there.
There you go.
So that's a way. See, I'll tell you, see, brought an AIMS example. See, if you, let us first understand what is primary health in a high level. Because primary health is very subjective. If you look at public health system, whatever is happening till the district hospital, that is, they have sub-centers or wellness center they call today, then that is there for every 5,000 population. Then for every 25,000 population, they have a primary health center. It's an empirical number. Sometimes it is more or less. Then every block level or taluk level, there is one hospital. And a district level one hospital. This is called primary and secondary care in public health system. Whereas when you come to private health system, it totally changes. A single man doctor clinic is predominantly defined as primary care. There are in the last 10 years or so, there are multiple medical offices, group practices are coming up, but that is very, very small. Then most of the secondary care happens in private healthcare in nursing homes and small hospitals. Then 80% of all healthcare services happens only in big tertiary care hospital. Last 40 years, we just changed this whole game. That big hospitals, their major way of serving the society is through OPD. And if 100 people comes to OPD, and there is a method, about 15% of them might become admitted in the inpatients. So now you take big hospitals, they don't private hospital, they don't make money on OPD, most of them on inpatients. If you go to the primary clinic, their major single man clinics are all like about 50 lakhs, 60 lakhs annual revenue. So now, to solve the larger healthcare problem, if a big player has to come and solve the primary healthcare in a private health system, traditionally, if you look at any analysis last 20 years, they'll come back and say, doing a primary health business is not viable. And in public health system, the challenge is, nobody wants to go and work in rural India. And most of the posts are vacant, and even if it is filled with multiple different level skilled people, and there's a huge access gap and availability gap. So this is if you put a snapshot of an India, the primary care, whether you public health system or private system, by definition, which is generally set up with lot of gaps. And last 5 years, if you look at it, it's very easy to say two things in healthcare. If you fix the primary health, there will not be any rush in AIMS and big hospitals. It's very easy to say, but how do you fix primary health? And then it is very easy to say, we have to proactively, preventive care. If you focus on wellness, you can stop illness. But why we are not able to do? By design, commercial design, we have set up primary and secondary health to fail. So the innovation on digital model to make an economic solution for primary and secondary to succeed. So I'll stop it here in the first round, then we'll go later.
No, very important point. So not only can we actually reach the population through digital because we don't have human resources, but what Girish has brought up is that even from an economics perspective, digital is going to be the way to actually get there. So, we normally think about digital and as expensive, but actually digital will reduce the cost. Because if we want to do population level work, then I think that's going to be important. Just coming quickly, to your point of wellness versus, illness. Primary care if I were to define it from a rural perspective, are the frontline health and wellness centers or health centers that are in the villages. If they are able to screen populations for diseases, if they are able to provide better diagnostics at the front line, we probably will see a reduction in disease burden. And that probably goes a little bit in the direction of wellness. So we probably will start finding some change there. And there again, I think technology like Cure, for example, or other such technology, I mean, Niramay, I think, is here, AI Steth is here. Those are the things that could possibly help us get there. But there is a large, there's a large issue of who's paying. And that is where, Ashutosh, I want to bring you in. Everybody has insurance. Can I see a show of hands? Let's see how many of you are awake. All have a medical insurance? Anybody have insurance which pays when you don't go to hospital? One person. You have OPD insurance. I want to know your insurance company. Even I want it. But insurance is a big challenge, right? And especially OPD insurance is a big issue. Could you tell us a little bit, because CARE works in the insurance piece, so could you tell us a little bit about how are we going to be able to finance OPD care through insurance, and what are the challenges? Why is it not happening? Because it works all over the world. There are organizations who are doing that, governments who are doing that. Even Ayushman Bharat insurance is not providing OPD care, not yet. So why don't you shed some light around that?
So Neeraj, when I joined my company, Care Health Insurance, way back 13 years back, one of the biggest data points that struck me was the fact that around 2/3 of our entire healthcare expense is on OPD, and none of our products had any OPD cover. Of course, it's a challenge, but then we started thinking as to how is it that you can bring OPD also into the ambit of insurance. And then we come to some very practical challenges. So first of all, today, if you ask anybody what is he really scared about, he would not say that I'm scared of going to my neighborhood practitioner. But I'm scared about going into the hospital because I don't know what the bill will be and how much I'll have to pay. So that's where insurance naturally fits in. But the truth is that there is a lot of benefit and insurance population can gain from having access to quality, timely, cost-effective OPD care. Because ultimately, it's about intervention at the right stages, which can enable, reduction in overall claims cost. Having said that, as an industry, while we have tried to bring OPD into the ambit of insurance, there are some practical challenges. One of those that we have faced is the fact that these are small value claims, and processing of those claims becomes expensive. Number one. Number two, insurance is all about ensuring that there is appropriate, healthy usage of healthcare and no overutilization or no fraudulent usage. Right? So these are some of the challenges which made OPD a bit difficult to crack from an insurance entity. But I think technology has a very big role to play. Primarily, while I understand this meet is about IoT and AI, and in insurance industry it has other use cases, definitely very relevant. But in OPD, I think the fundamentals need to be fixed with the help of technology. And one of the methods that have really evolved over time and hopefully will become more and more prevalent is where OPD is administered in a network of service providers, which works on a technology platform, which comes with many advantages. Number one, you are able to eliminate fraudulent claims. You know when a person has gone and availed OPD care at a network hospital or a network primary healthcare center. You can also, ensure that the customer gets the benefit of cashless service. Why should the customer have to first pay 500 rupees, then fill a form and wait for that 500 rupees to come back from an insurance company? And of course, the third and most important thing is that technology can first enable the customer to get access to primary healthcare on the spot at his home, and only if required, he has to go to an OPD service provider somewhere. So I think, of course, we'll talk about it a little bit more, but I think, OPD has now started getting solved a little bit. It's a long way to go, but hopefully very soon we'll have more inclusive insurance products in the healthcare space.
Tell me, I'll stay with you, Ashutosh, for a minute. ABDM has been talked about the whole day today. We had Mr. Gopal Krishna here, who's the CEO of NHA. Lots of conversations around ABDM. I think most of us probably don't even understand what's happening in its entirety. But having an ABDM type of a platform, and possibly if everybody does get on it, which is the larger wish list.
Yeah.
Do you think that kind of a thing could possibly solve this challenge?
Most certainly, I think, and I'll just take a step back. When we talk about technology in a network, can there be a better network than ABDM? There cannot be a better network than that. Of course, we have to see that today, how many primary healthcare service providers are part of that network, but I think it would definitely, so let me tell you, what is it that is critical for an insurance product on OPD to succeed? Number one, it should have a very wide network, right? So it should have your neighborhood doctors, because only then the product becomes relevant to his captive population, right? Number one. Number two, cost, right? When you have a large, a network like ABDM, of course, it also helps you bring down the cost of healthcare because of the, the contracts and the large volumes that come into that system. And these two things together can make OPD very affordable. Affordable, why? Because, one factor I would like to touch upon here is that it's not just about designing an OPD product, which is a calculation of how many people will claim and how much they will claim. It's also about ensuring that the end user finds it relevant and attractive to buy insurance instead of just saying that, okay, whenever I have an expense, I'll make it. Right? Today, if I sell a 5,000 rupee OPD cover and I charge 4,500 rupees for it in premium, it's not going to be attractive to anyone. Sure. So these things can definitely help bring, the cost of healthcare down, give better access, make the OPD product very attractive, and maybe, that can become a default option in all insurance products. Along with IPD, you have OPD as well.
Yeah, we'll have to see how this takes off, because, the rollout has been happening, and I don't know if all of us have ABA IDs, but actually ABA IDs got created when the COVID vaccination certificate got created by default. I don't think most of us actually took that on, and we're not using it, but hopefully it'll move in that direction. Girish, coming back to you, so policy level, you've been in this sector for a long time. I think I've been interacting with you for 8, 9, I don't know how many years, but you've been here for much longer than I have. So what do you see? The policy is shifting. What are the challenges you're feeling, or what are the things that we still have left which we need to do? And focus on primary care and
I'm going to only focus on primary care.
Perfect.
So that is the purpose of this.
Absolutely.
So, see, I'll tell you, current policy, whether it is technology related policy or healthcare delivery related policy in primary care, which is, while we are making a major push on ABDM, major push on digital, but the practicality of technology implemented, for example, if you are trying to do a remote consulting, or if you are going to do a home delivery of services or near home services, what are the possibilities? You will do telemedicine, you will do mobile van based, or you will go at home. For all of these, let's look at the regulation. Look at the regulation for pharmacy. Look at the regulation for mobile van. Mobile van, if you are using for diagnostics, it is associated to a particular diagnostic center. And it has to be a district specific. So it comes under multiple law. So every state has got some differentiation on this law. And then there are central policies. And then there are schemes to get benefit out of this. So there is a huge complication right now, because we are using last 30, 35 years regulations and policy on the current and future model. We are pushing very hard, very quickly into the future, but without not accounting for it. So policy needs to be relooked at in totality. And probably there should be a group of people at the central and state level as we form from the industry as well as from the government. Very quickly we need to push the envelope if the digital based healthcare is going to succeed. You take PACS, you take imaging, every teleradiology. How do you do it? A radiologist has to be physically present, or a gynecologist has to be present to do an ultrasound. And then we are talking about technology. GE says, I will do this. Philips says, I will do this. Practically, our regulation is nowhere connected to where technology is going. So that's a fundamental point.
Okay.
Now, I'll take you to what is the veracity of this regulation is not there, is going to create huge issue for us. See, we expect about 430 million Indians to become obese by 2030. Close to about 150, 200 million people is going to be diabetic and hypertension. This is not something where my friend is saying OPD, it has to be done near home. You cannot have a diabetic patient going to the hospital and waiting in OPD for hours. It has to happen very easily close to at home. Continuous care has to be given, through technology has to be given. So all this chronic disease, thyroid, PCOD, and all of these diseases requires continuous, proactive, day-to-day basis care, connected care. And it has to be close to patient. And it should be patient-centric. This is possible only because of technology. Now, it is not only from the perspective of digital, this, that, and all of it. As a country, the kind of economic growth we are projecting, if we don't intervene right now with the technology and disrupt the way we are providing the care, the way we are providing care in the big hospitals and clinics is not the way we can scale. The current method and model is not smart. So we have to very quickly invent. All the startup companies as a great innovation examples. We need to bring in all these things together into a single platform. ABDM is going to be one kind of that platform, which is going to bring these services together from the regulatory and the government perspective. There are mushroom of new services has to come in and close to patient.
Very interesting. You know, when you talked about the policy environment, and I work on the intersection of policy quite a bit. It's like, if you remember 10 years ago, if you went to Chandni Chowk in Delhi, sorry, I'm from Delhi, so I'll give you an example from there. The wires, you know, there were just so many of them.
Yeah.
You didn't know which was going where, and they were all sort of short-circuiting. And I think that's what we're probably falling over. Somebody needs to sit down and say, okay, this needs to be simplified, cut off, this new stuff needs to be brought in, etc. But isn't the external world also moving very fast? I mean, you know, I don't think we're able to catch up or keep pace. And maybe, I mean, I've been in some of these G20 conversations. I don't think anybody in the world is able to keep pace with the way technology is changing. It's just going so fast. But yeah, to your point, definitely we'll have to do something about it. And your point on chronic, I think that's pretty critical, because that is where we'll have to go. We'll have to start thinking of connected chronic care at home, self-care and supportive care at home. So I think that's an important one. Coming back to you, Shubhankar, tell me, what would you like to see changing in your district, city? Where do you live?
So basically I am from northern part of West Bengal.
Siliguri?
Next city,
Jalpaiguri.
rather town, Jalpaiguri.
Jalpaiguri, okay. Yeah, I've taken trains from there.
Yeah, I'll tell you my story. Last year, 12th of February, I got a call from my mother. Generally, we speak in the evening. She gave me a call in the morning. She said, not able to walk. Next day, we all traveled there, and I met the local doctor. Local doctor said, you know, some nerve element, you know, given the GABA for quite some time, nothing improved, COVID was still there. Then I thought it's enough. Now go for a teleconsultation with the doctor in Bangalore. She asked my mother to walk for a couple of these things, and some of the pain points I just try to show him, you know, how that reacts. And then he dropped me a message, Shubhankar, if you want to take the help of modern treatment, please bring her here. Because the local doctor said she needs to be like that forever. So I bring her here because of that teleconsultation, done all those tests here, X-ray, MRI, because in my hometown there is no MRI facility. And then it found both the hip were fractured, both the transplantation done here. Sure. Now last week she went back, you know, walking on her own feet. So that's the power of the teleconsultation, I guess. You know, where there is underserved area or not at all having the services, they can also able to, you know, get connected with the best doctors, best facility, and get the proper treatment.
And do you think teleconsultation is here to stay, or it was a COVID phenomena? Because I know that for the last 15, 20 years, many organizations were doing teleconsultation, wasn't really taking off. But COVID had suddenly took off. Yeah, Girish, you want to come in this time? Yeah.
So I remember 2016.
आपने भी किया था ना कुछ teleconsultation में.
So now first let me, when I get into telemedicine, teleconsultation. So 2016, that time the Central Health Minister was Mr. J.P. Nadda. He one day called me and asked me, and very seriously, a 45 minutes meeting. And the end of the meeting, he said, only one thing you make, Girish. Make telemedicine real. So this is what his statement was. So first let us decide what is digital in healthcare. Everybody thinks just by doing a telemedicine, video conferencing with a doctor can solve the healthcare problem. It can solve in an isolated and Shubhankar case where he is there in Bangalore, he has an access to people and all. But there are a lot more undercurrent below this. See, the kind of diagnosis to be done, the kind of digital information has to be put in, the kind of doctor's activity has to happen. All of that, because healthcare makes a very simple assumption. Everything is prognosis and diagnosis in a simple diagnosis statement on a consultation, along with a prescription or an order. If you talk to a doctor, what is his job? Especially in a primary care, you go there, you tell your symptoms, he will have his prognosis and diagnosis. Finally, he is going to do only two things. He is going to write an order for test for you, or he is going to give you a prescription. Now, as a technologist, you automate this through a virtual technology and say, we have done digital, it is done. Then the problem is very simple. There should not be any healthcare problem in the world. But the issue is much more deeper. The care, if you take diabetes, I'll give you a simple, I've developed one patented technology for diabetes and obesity. To treat obesity properly across all the different considerations, you need to consider 1600 parameters before deciding your treatment plan. And there are some doctors, they do it by training, but mostly if you need to consistently do, whether you use ICD-10 or FHIR standard, or if you want to use technologies of some of the other companies' technology to care pathways, anything you use, finally, there's a large amount of data has to be processed and given in a consistent manner for all the practitioners to fax. That is digital, not just having a telemedicine. And telemedicine technology is already, there is one way we have tried this in cancer and primary care. What we did is between the doctor, senior doctor and a patient, we brought in an in-between person like a junior doctor or a junior practitioner. He does most of the work for the doctor, most of the healthcare driven through the technology. We call for a purpose called digital worker, but it does a significant impact.
I saw something digital here.
Yeah, so.
And we are about to go on to alarm.
Yeah, so, I'm sorry. I'll stop it here. So that really worked in telemedicine. So what I felt is, instead of having a two-way communication, a doctor and a patient, there's a system behind it. There is a separate person who mans it, who ensures that the well-being of patient as well as the correct treatment from the doctor.
Fantastic.
So,
Okay,
so
yeah,
in
go ahead.
this
Come.
line,
1 minute.
1 minute.
Yeah.
BBMP, Namma Bangalore BBMP created a digital center
Yeah.
in one of the PHCs here. Where there is a person sitting and having different equipments, and those are connected equipment, and doctor sitting in command hospital, and
Yeah, absolutely. There's a lot of that happening. Unfortunately, small pilots,
Yeah.
but a lot of that going on. Okay, so we are here to talk about, we have 3 minutes, AI and primary care. One thing that you think you would put your last dollar on if it was AI and primary healthcare. Whoever's ready can go. For me, it's disease prediction, modeling. I think that would be a big one.
I think AI is the next big thing, and that needs to be taken to the last center as well in PHC setting.
Okay, great.
Then it will give the better benefit.
Fantastic. Girish, you ready?
Patient communication.
What communication?
Patient communication.
Patient communication. Fine. Yeah, so you're stuck with patient communication for sure. We have to fix that. Go ahead, Ashit.
No, I go with you, Neeraj. I mean, no doubt, the tremendous amount of data that primary services can provide can help in prevention, prediction, and reducing the impact of the disease burden. And that, I think, if we can solve, it's the biggest service to
Yeah, I would put my bet on two things. One is screening and diagnostics, where I think AI could really be useful. Yeah. And the other one would be sort of predicting disease modeling, looking at where, and with climate, especially I work a lot on infectious diseases. So climate and vector-borne diseases, and you can actually start predicting and taking preventive action. Yeah, we still
So,
have 2
Neeraj,
minutes.
one point
Go
there,
ahead.
when I say patient prediction, the patient communication, you predict, and for example, you are arriving this Bangalore this morning. When you took a flight from Delhi, you get a prediction saying that, okay, you need to take an Allegra in the night before sleeping. Yeah. That's what I meant by patient communication.
Brilliant, absolutely fantastic. And that's something also which we are doing in AI, looking at what is the chances that a person who is suffering from TB is not going to take the drug. So, adherence of treatment. So that's also sort of same part. So we've got a minute. I don't think we have time for questions. What I would suggest is the panelists are here. There is, I believe, the organizers have tea or coffee outside. So why don't you just catch them before they run off and ask your questions? Is that okay? Yeah? Sure. You all agree? Yep. Because we can't do that in 1 minute and 15 seconds. So thank you so much. Thank you for being a wonderful audience. And thank you for staying till the end. I mean, when I was told this is the last panel, I said, koi bhi nahi hoga. This is going to be an empty hall. So it's good to see that we still have more than half a hall here. So thank you. And thank you to the organizers. Thank you, NASCOM.
Thank you, panel. Could we take 2 questions from the audience?
Yeah.
Yeah, it's on your time now.
Any audience questions? Because the buzzer is yet there. Any questions? Okay, could we have the mic there?
I don't know how you guys look at this, but we talked of primary care, and you all are very evolved personnel in the healthcare industry. Is there any focus that India has on preventive care? Because the medical insurance in India is pretty bizarre to best of my knowledge. We don't do annual checkups. We don't focus on, we meaning India, doesn't focus on preventive care. So what's your view on that?
Can I take this one?
Yeah, please, go ahead.
So, sir, I started my career in health insurance specifically 13 years back. The very first product that we bought out had a annual health checkup built into the list of benefits. And we offered it on a cashless basis. And we made a lot of effort to communicate to the customers that, hey, listen, you have already paid for it in form of a premium. You just have to go, we'll book the appointment, you have to go there and be present at the right time so that a comprehensive annual health checkup can be done. I believe, in the best of efforts yielded us about 40% participation. So if there are 100 adults, 40 of them would actually go and, conduct their annual health checkup. So, we have tried a lot because, of course, for other reasons as well. For example, insurance is such a product that has a very low engagement with the end user. Only a fraction of the people would end up in a hospital, and thereby, we don't have means to engage with the customer. So we also thought about annual health checkup as a method of providing some value to the customer, even if he has not ended up in a hospital in the last 1 year. So of course, we are very positive about annual health checkup. We have been having it as an integral part of all our insurance products ever since we launched. And I'm not just speaking about myself. I think today a large number of health insurance products from various insurers do have annual health checkup, built into them.
I think it has something to do with our culture also. I don't know how many of us check the stagnant water in our houses. I don't know, are you aware that dengue is on the rampant rise? But how many of us actually take preventive measures, I'm wondering. So I think we're sort of Indiana Jones mentality a little bit, yeah. I believe the organizers had one more question, right? Anybody else?
No, I think we will close it down.
Sure,
but
okay.
you will have them over the cocktail, samosa. So it's not cocktail.
I think the gentleman already has the mic.
one question.
Okay.
Yeah.
But make it like a tweet, 144 characters, please.
Yeah, so my question is specifically, I spent in my previous job a lot of time wandering across rural India and taking feedback for several healthcare technologies. And what I realized was with all of these technologies, which were very cutting edge, nobody spoke to the nurses. There was a big gap between the ASHA workers and the ANMs and the product designers, which were usually, male engineers in an IIT or some other place. And how would that gap, how can, as leaders like PATH, etc., can there be any policies in place to make sure that these voices are heard? Because one of the nurses told me, you want to make my life better, don't give us technology, give me a two-wheeler. And
maybe I'll just answer that. So, I think most of these innovators who have not done their homework they realize very soon, because economics is a tight slap, right? They can't sell their product anymore. So I think, I think that's but human-centered design, you have to do it. There's no question about it. Everybody's talking about it. And a lot of organizations are doing it. So it's just learning from failing, probably.
Thank you. Thank you, the panelists.
Thanks
and
a lot.
The moderator. Very nice. A round of applause for them and the photograph. You know, in India, we eat desserts at the end, right? The sweet. The best comes at the last. All right. We'll have Kotaro-san. Kotaro-san, if you can hear me, please please run here. We have this Japanese startup. It's very similar to what we've been doing here. You know, over 2 years of COVID, we've been on Zoom and Teams. And this gentleman who has come all the way from Japan, he's got 150 patents. Can you believe 150 patents? And what he tries to do is, he's going to explain, but what I understand is he can find out who of your employees are in a distress, mentally not good enough, or XYZ. Here to you, Kotaro-san.
Hello? Yeah, okay. So first of all, thank you so much for your kind introduction, Nabartan-san, and Bahat Dhanyawad for giving me opportunity to be here. My name is Kotaro, and I understand today we all got a lot of learning through fabulous inputs already. So I want do that, and even I don't know much in detail. So on behalf of that, let me introduce my story a little bit. Actually, I came to India 5 years back, and basically what I'm doing is social work. I'm visiting rural area and slum areas in India, almost 6 states. Of course, Bangalore is the one, Karnataka, and Tamil Nadu, Bihar, Delhi NCR, Gujarat, and the West Bengal, and I think that's all. And as all of us have experienced the COVID situation, that time I was, of course, also in India. And obviously, I cannot visit all the places where I connected. So what happened was that, what I did was that I shared the fact what was going on there, here and there, to the Japanese and the Indian friends, and got some donation and distributed food and medical support, since that was the emergency situation. But unfortunately, obviously, I couldn't help all the people who I know. Like one father in the village in Gaya, in Bihar, unfortunately, he passed away. Not because of COVID. He conducted the suicide because that time he lost every single hope. So what I felt is that obviously still I cannot visit all the places at the same time, but what I can do is to connect through phone call or of course online video calls, or maybe I'm able to connect some online therapy service for him as of now. So fortunately, 2020, just after the COVID happened, this company, I'm Beside You, was founded in Japan. And they are visualizing the online communication. So coincidentally, that was the same time I felt the power of online communication, and they started. So let me share about this company. Yeah, as we all understood, through remote communication, we cannot share much about the emotions. Well, of course, if you are managers, we cannot get the how they are feeling, how team members are feeling, and what kind of communication is going on in other team members. So this black box is there, but of course, there is some positive side of remote work, like well-being, Or, of course, we are able to have more time with family. Like this positive side is also there, as we understand. So what we are trying to do is to keep the positive side and decrease the negative side by this technology. So basically, we have developed a multimodal AI. We are analyzing video online meeting, like it says, like facial expression, face orientation, gazing, and voice tones and all. Okay, these are some small criteria. Our experience. We collaborated with IIT Hyderabad, or currently we started to collaborate with NIMHANS in India. Yeah. Let me skip some parts, since these are just explanation about the issue of the mental health. So we have two solutions, Pulse and Mindry. And we have the booth behind. So about the detail of the products, we are able to explain in the booth. So let me explain just a summary here. Let me skip, yeah. So Pulse and Mindry. So Pulse is basically revolution in the collaboration. So basically for HRs or the managers to visualizing the communication and getting to some ideas what we shall do for the team members, mental health, to prevent from burning out. And Mindry is focusing on the mental health itself. And this product is for the therapist, professional therapist to utilize. So let me skip some part again. And yeah, this is a Mindry. So as we can see, like there's a client, we can sync the patient, and we record basically we utilize online session with patient and the therapist. And the therapist is able to see the record, of course. And they don't have to record by themselves because the AI generate summarize by themselves. I mean, like by AI, our technology. And the most important thing is that we are not trying to replace the therapist. We are not diagnosing. We are supporting them to do that. We are just getting the emotional data, relative change of the exact same patient, and share the data so that therapist can think like what we shall do. Okay. Yeah, these are the team. Basically, founders are all Japanese, and occasionally they come to India and they stay here, Bangalore as well. And many Indian members are here. Yeah, all the members are from IITs as of now. And more than 10,000 applicants from IIT and IIM students for our summer internship. And we worked very closely with them. And we got some remarkable hours. Yeah, so as I said, there's a booth, and we are offering free trial today. So if you are a decision maker, you have the right to decide. And if you have to manage team members remotely, including like hybrid style, or if you have other branches, and if you have any doubt about the team members, how they are doing, and if you want to take care of their mental health, please visit our booth there, and yeah, let's discuss there. Thank you so much.
Thank you, Kotari-san. I hope you will get some very good market traction in India. Let me invite you all for a cocktail plus samosa, or is it cocktail samosa? So Vasuki has cheated me. He promised cocktail, but he didn't put a comma in between. So I think it's a cocktail samosa, which we'll love to have with you. If there's anybody who's done that, cracked that thing, please come over here, demonstrate to everybody, and we have a gift. Anybody who wants to try? Anybody? Come, please come. Yes. No. Going in the same circle. Anybody else? Come running, yeah. You have to have the energy to run. Come, Shiza, do you want to try? Try. No, slow. We can't watch. right? Yes, he's doing it right. Were you listening to that panel or not? Okay, thank you. Wait.
Seems like he doesn't want.
Anybody else? Unlimited gifts. This is the last occasion. Anybody else? Okay. You want to try? Okay, try it. Shita, do you want to try? Oh. Okay. Maybe you can try after we clear these songs. If anybody doesn't, please go ahead.
Let's all try. Come on, everybody. Let's see who's grabbing the gift home.
Anyway, you may get some energy after the tea, coffee, and the bottles of massage. Thanks a lot for all of you. With us, I'm sure we started to have some very good traction. A lot of good leads and doctors